And our third speaker is going to be Jorge Plutsky from the Brigham Hospital in Boston. And he's going to talk to us about new therapeutic targets in lipids and atherosclerosis, exploring the pipeline. Welcome, Jorge.
Professor Fouchard, Jamila, for the invitation. It was an incredible program, exciting to hear all the discussion about PPARs and PPAR alpha. This morning, Peter Libby was the first person ever to say the acronym PPAR to me out loud from another person. It set off years of work. And Jean-Charles, the first time I ever presented internationally our data that PPAR alpha activation could decrease endothelial inflammation, Professor Fouchard came up to me. Of course, I was intimidated and scared, and he said, "I have a very good feeling about your work." And I said, "Oh, that's nice to hear." And he says, "Because we've seen the exact same thing a few months ago." So, and he's continued to challenge me, and he challenges me with his talk about exploring the pipeline. And let's set some parameters as we think about what we're looking at. The very first one, of course, is that there won't be enough time, so if I don't talk about the target you're excited about and thinking about, you'll forgive me. But looking at what's coming in this area, I think there's a few things that we can talk about. There are established agents that are going to move into new indications. I have an example or two of those. We have established pathways that may have new approaches. We have unmet needs with new therapies, and I'm going to try and concentrate on ones that have not shown up yet in our discussions. A novel pathway with a failed agent that may still have some promise, and then new therapeutic strategies. Now, the outline here in the menu, in each of those categories in yellow, I knew would be covered and have already been touched upon, so I won't get into those, and we'll have Marsu talking about NASH, so I'm not going to get into that. But let's go into some of these. The first one, established agent with new indications. So here's a patient of mine who has homozygous familial hypercholesterolemia. He's on max therapy, including a PCSK9 inhibitor. And here are his numbers in US metrics. But you can see an LDL there of 490. And we did get him approved for evinacumab Evkeeza as an ANGPTL3 antibody based upon the data. And in fact, he's had a good response, still much too high, refuses apheresis, has not had cardiovascular events, is in his 30s. But in terms of this pathway that we've just heard quite a bit about, it certainly lowers LDLs, we've seen with that patient, but it also lowers triglycerides. And you can see here in a cohort of individuals, the details are not important, looking at a whole variety of different genetic variants, that you have many different responses in terms of the triglyceride effects. Some of them are going up, but many of them are going down. And I just want to highlight here an issue that doesn't get enough attention, is this one, which if you work in a lipid clinic, you see these patients, and they're often quite sick, often admitted to the ICU, often in a recurrent manner, 20% readmissions. Some of these are even life-threatening, and often persist even after maximal triglyceride therapy. And there are many genetic conditions that contribute to that. And now we're looking at use of ANGPTL3 antibodies. Here's a clinical trial that's looking in patients with severe hypertriglyceridemia about trying to prevent recurrent acute pancreatitis. And there's a few of these, but I think it's an important aspect to this field that doesn't get enough attention when we're seeing triglyceride lowering. This potential for its use, and ApoC3 can be on that list as well. Really a separate condition than cardiovascular risk is this need in terms of recurrent acute pancreatitis. So here's another established agent with new indications for the GLP-1 receptor agonist. We've only heard about this in passing here today. But it's an exciting, I think, and seminal observation that I just want to take you back to. You know, whenever I'm pointing at that, you can go ahead and advance for me. So here's an incredibly simple, elegant, beautiful finding in 1967 by Kipnis and Perley. And if you gave individuals glucose through their vein or through their mouth and achieved the exact same glucose levels, it was through the mouth that you were always getting a bigger insulin response. And it's simple and elegant, and reflected by the fact that that was done in 2 patients. And yet the protein accounting for this was not known, but it turns out to be GLP-1. And so now we have GLP-1 receptor agonists and a variety of landmark outcome trials here in the bright green are all the ones that were positive in their primary endpoint, not across the entire class, but still quite remarkable and quite notable about their impact on atherosclerotic complications in patients with diabetes. And so now as we push on, we'll see SELECT soon. Asking the question is, can a GLP-1 in high-risk individuals, prior MI, stroke, or symptomatic peripheral arterial disease decrease cardiovascular complications in people who don't have diabetes but are obese? And this could be quite important. I serve on the steering committee for this and fully enrolled, and we look forward to the data. But will this be more conclusive evidence that obesity is a mechanism in atherosclerotic complications? And what's at work there? A direct effect, effects on inflammation, on triglycerides, or even on NASH. We'll see that, but I think it will expand in terms of our pipeline. And part of that pipeline also relates to the fact that this is a first generation of studies. We now have dual agonists on their way. And here you see the regular GLP-1 receptor agonists and their effects on weight. But in the combination with a glucose-sensitive insulinotropic polypeptide, GIP, in the form of tirzepatide, really a quite remarkable impact on weight reduction. Percent body weights of 16 to 17%. And so will this correlate with even greater reductions in cardiovascular risk, or the conversion of these individuals to type 2 diabetes or to NASH? And will those mechanisms be direct or indirect in terms of cardiovascular risk through that weight reduction? And I do think that these are some already approved, although currently only for treating diabetes, not for obesity, but that's coming, and as are the cardiovascular studies looking at risk. And I think this is going to be the tip of a whole new era of second generation of these agents, with dual GLP-1 receptor agonists and glucagon receptor agonists that may have distinct effects on things like NASH. So this has already come up a couple times today, and I thought about eliminating it, but let's just go back to this idea that an established pathway here, but new approaches. Here are all those old movies we heard about this morning, that we know how those came out. And the question is, well, can we do better about the many different reasons why these failed? Obicetrapib. And here's just, I want to highlight the point that Alan referenced. Much greater CETP inhibition with obicetrapib. Does not have the half-life issues in fat that led to some of the challenges with anacetrapib. Does not have off-target effects on blood pressure to the extent that was seen with torcetrapib. So we'll see where this goes. We saw this in a more animated form of how CETP is interacting here, but it does also affect LDL receptor levels. And so we've really moved away from the HDL component. We have Mendelian randomization studies that do support the idea that CETP loss of function and the CETP activity correlates with decreased cardiovascular risk. So will obicetrapib be able to achieve that? It's not clear. This is the kind of data we see. The TULIP phase 2 studies, LDL changes with obicetrapib greater than what we had seen before, either alone or here in combination with a statin reaching 70%. And then we've recently had, from another early phase study, the ROSE trial, here these changes on ultracentrifuge LDL, and also interesting on lipoprotein little a. And so will this be part of the story of how this comes forward? We'll know because now there's funding for a phase 3 study looking at cardiovascular outcomes and heterozygous FH and atherosclerosis. So we can advance. Unmet needs. We've not heard about Lp(a) and therapies for that. I think it's an important thing. It's certainly something that we see a lot of in clinic. Patients coming with strong family histories or established disease early on. And we've had even more data, adding to what we had before in terms of epidemiology, Mendelian randomization, and genome-wide association studies that showed association with risk. This is from our colleague Samia Moore at the Brigham. Further support, as we've seen from many different inputs, that Lp(a) is correlated with risk. Now, how to target that? Well, our strategies at the moment in this very complex molecule, one involves an antisense, pelacarsen, which can significantly reduce Lp(a) levels. This trial is now enrolling, and we've completed our enrollment contribution at the Brigham. We'll see what the impact is on this. This is a real unmet need. A second strategy led by our colleague at the Brigham, Michelle O'Donoghue, is with a silencing RNA, olpasiran. And here again, you see dramatic reductions in lipoprotein a. And we have other targets. This, of course, is not an exclusive list. But one of the intriguing aspects of this is the suggestion that whether one needs this degree of Lp(a) lowering to change things clinically. So here's 2 articles from JAMA Cardiology with an editorial raising the question of the extent of reduction we need and in whom. In this first report, there was a suggestion you needed a reduction of absolute levels of at least 100 milligrams per deciliter to change things clinically. The second paper suggested that may not be quite as high as suggested from that, but that will be, of course, interesting. And then also these more aggressive approaches, there's been an association genetically of people with very low Lp(a) that may have an increased risk for diabetes. Will that complicate the story? Is not clear, but certainly an exciting one. So now novel pathways in terms of a previously failed agent. I just want to get into an aspect here of new therapeutics in the pipeline that we haven't talked about is epigenetics, and an example of this is through the BET pathway that we've been interested in studying. So epigenetics is really in its most compelling form a way of creating biologic memory and doing that independent of changing the genome. And this system is a very elegant one. It solves a major problem that we have just too much DNA to fit in the nucleus. And how do you solve that? Well, you solve it through DNA compaction, of wrapping DNA tightly around histones, which then solves that issue by condensing DNA into these structures of DNA tightly wrapped around histones and their signature tails. And that is a solution to that, but the issue is that in order to control gene expression, this chromatin has to relax in order for transcription factors to associate with that DNA and execute the expression programs that are needed. And so this epigenetic code, completely independent of changing DNA, is one in which a series of enzymes can place a mark or remove a mark, writers that place that mark or erasers that remove that mark, that essentially become a way of a cell recording prior exposures and then executing that program, all independent of having changed the DNA. So this could be something associated with exposure to cigarette smoke or with diet or gestational diabetes, where now a transcriptional program is being run by the placement or erasing of these marks. And this system also involves a third component, which is those marks, once placed, have to be read, and a third family of proteins that are these readers of those marks. And so one of those reader families are these BETs, the bromodomain extra-terminal domain protein, the BETs family. And here you see them with one of those family members, BRD4, bound to an acetylated lysine on a histone tail, and now that becomes a scaffold that lets the entire transcriptional program, including polymerase II, transcribe genes. And the BETs, in so doing, are coupling these transcription factors to the DNA and this entire transcriptional machinery. So in executing gene expression, not of just one gene, but an entire coordinated program, it involves this epigenetic reader protein. And one of the things that allows us to study this has been the development of inhibitors. And you see here with the BRD4 inhibitor, this JQ1, which fits into the pocket that binds to that acetylated lysine. You disrupt this transcriptional complex. And so now expression is not occurring with these inhibitors. We've been very actively involved with studying that, and you can see here the amount of BRD4 that accumulates in an endothelial cell in response to TNF-alpha is the entire TNF-alpha, NF-kappa B, P65 program. Each of these lines is another gene that's responding. And that when you inhibit that process, you shift these transcriptional programs here induced with TNF-alpha and repressed in the presence of that BET inhibitor and decreasing atherosclerosis in the LDL receptor knockout model. It's just not atherosclerosis. This is our data with adipogenesis in response to the upstream inputs controlling adipogenesis, like PPAR gamma. And you can see here the dramatic shift of here under control conditions turning on a whole host of genes involved in adipogenesis, but not in the presence of JQ1. And then equally impressive is what it's doing in the myocardium. So when you do transaortic constriction across the aorta, the controls aren't changing, but here you see the repression of the cardiac hypertrophy that occurs with transaortic constriction when you've blocked the BET. So regulating entire programs through that kind of response. This has been a great interest in various different fields, and one of them is in diabetic complications, where epigenetic mechanisms, not just the reader proteins, but also those other writers and erasers are thought to be involved in the pathogenic program that's occurring, whether it's inflammatory in response to glucose or otherwise. And this data led to the development of therapeutics, including the first clinical cardiovascular trial asking if a BET inhibitor, apabetalone, could reduce major cardiovascular events in patients with acute coronary syndrome and type 2 diabetes. That was a negative study, did not show benefit. The trends were encouraging, but did not show benefit. Many potential flaws with what might have happened here. But I do think it points towards the future of this entire therapeutic area. And I had the opportunity to write the editorial for this in JAMA. And I think it captures something about this future, about the possibility that of taking the system of writing, erasing, and reading marks. Is it possible to also have cells and organisms forget those marks and ignore them and not be committed to repeating an inflammatory program or an LDL program or a hyperglycemia program? Apabetalone is a weak BET inhibitor. It's quite distinct, so the other inhibitors are different. It is, however, I think, an important novel mechanism. Can we use it to treat? It's not clear. Maybe it's too important, too central. I think an interesting observation is one we've been studying quite a bit in the lab, is that these BETs aren't just acting in response to pathogenic inputs. They're also operative under basal conditions in unstimulated cells. And so here you see some of our own RNA-seq data looking at the entire transcriptome in endothelial cells with and without a BET inhibitor. And what you see is that they are involved in maintaining what could be considered the physiologic program of what keeps an endothelial cell healthy and active, and we're harnessing this to find new targets. And of course, this leaves aside the possibility of targeting writers and erasers, which is very active in the field of oncology, and we'll see where that goes. There are many ongoing BET inhibitor trials. Apabetalone is trying to see if it can do something about the signals it saw in heart failure, but there's other BET inhibitors being considered that may be different than apabetalone, and it is being pursued in cancer, inflammation, and even in HIV, which we can talk about. And then the last one, maybe the most dramatic one that hasn't come up yet today, which is base editing. This possibility that we now have the tools to go in and alter the genome and change it as laid out here, and as perhaps advanced most fully through Verve as a biotech that has a very specific adenine base editor using unique PCSK9 guide RNAs and then a non-viral system for delivering. And this, of course, is the possibility of, independent of everything we've been talking about today, could you treat a patient once and have treated them forever? So-called one and done. That, of course, raises concerns about the reversibility, but it's also quite exciting about the possibility of really making a difference. Being pursued for PCSK9 and ATGL3, but the PCSK9 is the furthest along, and here's one of those reports from the Verve group's Sake Catherison, and showing that with PCSK9 in this treatment, one could dramatically decrease the amount of PCSK9 and have a durable effect. This is 224 days out, and here's the change in LDL in primates in response to having made this modification. There's been a follow-up paper to that recently in Circulation from the same group, and again showing that you're knocking down PCSK9 in a dose response and decreasing LDL consistently and in a maintained way. A whole new set of issues, of which a primary one has to be safety. And here is their data just showing, am I going to spill over and not just affect the liver? Here you see a whole host of organs in mice that you've not had this targeted approach in the liver spilling out to other organs. It is seen, however, in the adrenals and the spleen. Does that matter? We'll see. It's certainly going to be a hurdle to overcome. And then here's the evidence that the Verve group has that when you treat female mice, that you're having this effect on liver PCSK9, but you're not transmitting this in the germline. The offspring are not carrying what you treated the mother. And this is the kind of safety hurdles that we're going to need. And we've actually had the first dosing in humans. And so, where will the story go is an exciting and compelling one. So we've gone through a good number of these. I think if we take a step back and think about it more broadly, that clearly, as we've seen throughout today, that we're going to have an increasing need for more precise identification of patients of who is at risk and has residual risk, given our therapies that we already have in place. And even in that context, there are great opportunities ahead of advancing targeting of therapies that we have and pathways we know, that we have therapies for completely new targets, like in lipoprotein(a). I think it was quite exciting. And then completely new approaches, including epigenetics and gene editing, that part of this evolving story will involve safety. And let's also acknowledge the challenge that we'll have as we move forward in these for successful cardiovascular outcome trials. I'll finish with one little notion, just because it's one that gives you a little bit of a sense of Boston. Paul Dudley White was a preeminent American cardiologist. He was an early advocate for lifestyle, diet, and risk factor control. He would bicycle to work every day and was famous around Boston, being seen on his bicycle. Here throughout the 1940s, 50s, 60s, as a matter of fact, our bike paths next to the river are named after Paul Dudley White. And when he passed away in 1973, here was the cartoon that showed Paul Dudley White making his last house call, which was in heaven. Paul Dudley White in 1973, or well before that, said a heart attack after age 80 is the work of God. But more important to us is before the age of 80, it's a medical failure. That was quite a statement in the early 1970s to say that. Look how far we've come, and yet look how far we have to go. Thank you.